I'm Dr. Chowdhury. I'm one of the psychiatrists that works at Feel Like RTMS. Feel Like RTMS is a RTMS clinic that offers repetitive transcranial magnetic stimulation in Toronto. And I go between Toronto and Vancouver. In Vancouver, I'm also an inpatient geriatric psychiatrist. So I work with older adults. I work with patients who have neurocognitive disorders and related disorders. And then I also help with the ECT program in the hospital. Um, I've also helped with these TMS programs across the country. So I've helped with TMS programs in Calgary and I've helped with TMS programs in Vancouver as well. So the purpose of this talk was to um, maybe provide some more information about TMS and other treatments like ECT and ketamine. I think ECT and ketamine people are starting to know about this, but and ECT has been around for a while, so people have heard about it. RTMS, I think, in the province of Toronto is relatively new, even though it's been a treatment that's been around since the 1990s. I think Ontario's been a bit slow in terms of the treatment becoming more and more available, but though it is available in a few of the hospitals, like CAMH has it. Um, some of the other hospitals have smaller ECT programs. And then there are private clinics, like one of the clinics I help with, which is Feel Like or TMS. So I thought today what I would do is I would tell you about our TMS and tell you about all the different indications that it can help with. And then I can talk to you about ECT and ketamine assisted psychotherapy as well. Now, the purpose of this talk is really just to provide information and maybe create some excitement about these treatment modalities, as there's a lot of research done around it, especially ketamine and TMS. But one thing to keep in mind is that in general, the research is still limited for many of the conditions. We're still trying to learn more. There'll be more and more studies that are done over time. These treatments that I'm going to talk about today, they're not meant to uh, be curative, but they're meant to help. They're meant to help with the symptoms quite a bit, and the treatments are not necessarily a replacement for the other treatments that patients may do. It's not a replacement for psychotherapy. It's not a replacement for medications or other treatments. But when used in combination with everything, patients can find a lot more benefit. And it's something that hopefully will be more and more accessible over time. So TMS is transcranial magnetic stimulation. It's a form of non-invasive neurostimulation that involves using magnetic fields to stimulate specific regions of the brain. And these regions of the brain may be acting abnormally in various psychiatric conditions like depression, and TMS helps to normalize those circuits. The good thing about TMS is that there's zero systemic side effects, so there's no known systemic side effects. So people can maybe experience a little bit of mild discomfort from it. It doesn't have any negative cognitive effects. It doesn't have any negative effects on the body. There's certain risks that we will talk about, but overall, it's a very safe treatment. And it's really based on Faraday's law of induction, which is from 1830. That's when basically that law states that whenever electricity goes through anything, it generates its own magnetic field, and that magnetic field in turn generates its own electrical field. So to put that into an example that you can maybe relate to is when you buy a new cell phone today, you don't necessarily need to plug it in anymore. You can just put it on a charging pad and it just charges. That's because that charging pad has a coil in it. Electricity goes through that coil. It generates this magnetic field, and that magnetic field in turn generates its own electrical field within the phone's battery and allows it to charge. And so we use that same science, that same technology in TMS. So what we do is we we put this coil over someone's head, and they're awake during it. Then there's no anesthetics required or anything. And electricity is going through this coil, but it's generating this magnetic field, which in turn then allows us to stimulate those neurons uh, non-invasively. So by delivering magnetic pulses, neurons are stimulated to fire in a repetitive manner, and establish connections with neighboring neurons. With repetitive treatments, these connections can multiply and rewire neural circuits, resulting in the normalization of brain regions responsible for mood and regulation, or and depending on the condition, other circuits. So it works in various ways. One is that we're stimulating those pathways, and those pathways are getting stronger. Then there's pro-neurotrophic factors that are somehow being released because of this treatment. It releases factors that are good for neuronal connection and growth. And somehow there's whatever treatment that we do, there seems to be downstream changes. So the whole brain is connected. So even though we may target, like, for example, the left dorsolateral prefrontal cortex, there could be changes throughout the brain. Neurons, as you know, obviously play a pivotal role in the organization of the brain. They serve as the fundamental building blocks, but then they form networks together, and these no networks um, form even more complex circuits. And those functional networks within the brain are dedicated to specific tasks and functions that are critical for our daily lives. And these functional networks are responsible for things like regulating our mood, coordinating our movement, enabling us to perceive and interpret the world around us. Um, and so TMS is based on that idea that there's these circuits that regulate mood um, in the brain, and there's different circuits that regulate other things as well. And what we're doing with TMS is we're tapping into those circuits and trying to shift them to being more like they are when they're healthy, because we know that there is a shift in these circuits um, when people have abnormal conditions. For example, if you were to take many people with depression and you compare their brains to people who are otherwise healthy, you do see there's a difference. And the brains of people who are depressed, for example, they're stuck in this negative state. They're more sensitive to negative stimuli. Their brains light up less to positive things. It's more difficult for their brain to shift out of that negative state. And when treatments are effective in psychiatry, we do see those circuits looking more like they are when they're healthy. And it doesn't matter what that treatment is, whether that's TMS or medications or psychotherapy. If effective treatment results in improvement in those circuits looking more like they're when they're healthy, and TMS is just another tool. So like I said, in TMS, we're targeting, traditionally, a TMS has been for depression. And so we're targeting the circuit that's regulated for mood. And that there's a circuit that goes from the limbic brain, these deeper structures in the brain, like the amygdala, the nucleus accumbens, and the cortical brain, the prefrontal cortex. And the two brains talk to each other. We target the prefrontal cortex, but we know that there's changes throughout the entire circuit. The other concept that's important to know in TMS is in understanding why it works or how it works, is that we know that the brain actually communicates with itself in different frequencies. And so we know that certain frequencies lead to connections becoming stronger and becoming more, and that part of the brain becoming more active, and low frequency um, electrical patterns in the brain result in decreased activity in that part of the brain, or decreased activity in that part of the circuit. So what we can do with TMS is we can pulse our magnetic pulse and our electric signal that we're sending to the brain to communicate to the brain in those frequencies. So we can use high frequency to bring up activity in part of the brain, or we can use low frequency to bring down activity in part of the brain. It's a bit difficult to wrap your head around, and a lot of this is they found out just from animal studies or basic research, and so it's just a rule, like a rule in neurons, that high frequency brings up activity in part of the brain, and low frequency stimulation brings down activity in the part of the brain. Probably in the future, as people understand how the brain communicates with each other, we'll understand that more. So at TMS, the treatment is actually individualized, meaning that every one of our brains requires a different amount of stimulation to activate it. So what we do with TMS is we target the left dorsolateral prefrontal cortex, or we target different parts of the brain. But how do we know how much energy is needed? to stimulate your brain. So what we do is we put the coil over the part of your brain that controls your finger or your thumb. And we slowly go up on energy bit by bit until we can make your finger twitch. And if we can control your finger from your brain, that means we have enough stimulation to be able to um, stimulate your brain. And then we put it over the parts of the brain that we want to treat. So what can patients expect? I mean, this is an outpatient procedure requiring no sedation. People usually sit in a recliner. It's similar to like a dentist chair, to be honest. Some clinics, it's just a normal recliner that they get from any store, like a IKEA. And the treatments they can be as little short as 3 to 5 minutes, or they can be a bit longer, up to 15 minutes. And usually people are doing treatment daily. So the term comes from repetitive transcranial magnetic stimulation. The term comes from the fact that the treatments are being done daily for about, for some treatments, it's 30 treatments. For some conditions, it's less. For some conditions, it's more. But it's that repetitive stimulation of those circuits that results in the change. So TMS has been mostly studied for depression. Like it is a Health Canada and FDA approved treatment for treatment-resistant depression. And there's been numerous uh, double-blind placebo-controlled trials that show that it's effective for depression. And so what that means for double-blind placebo means that there's a group of people getting TMS and another group of people getting fake TMS. So they're still getting the device put on them, but it's not real. There's no real stimulation being given. And neither the clinician or the participant knows if they're getting the real thing or not. And in those studies, TMS has been shown to be effective, and it's been replicated across the world. So, but why is such treatments needed? It's because treatment resistance, as you guys all know, in psychiatry is quite common, that patients don't always respond to the treatments that we have readily available. So sorry, the slide they got a bit altered when it got converted, but it's supposed to say treatment resistance is common. Um, One of the famous studies in psychiatry is called the STAR-D trial. And that's where they looked at like the effectiveness of antidepressants in the community. And they found that like, yeah, if you have depression and you go to your doctor and you get prescribed an antidepressant, yeah, about half the people will respond to it. Half the people will get some noticeable, significant response to it. But if you don't respond to that first antidepressant, your family doctor will prescribe you a second one. And the likelihood of you responding to that second antidepressant lowers. It's no longer 50%. It's down to 27%. And then let's say you fail that second antidepressant and they give you a third one. Well, then the likelihood of you responding is only 15%. So once you've tried a couple of medications for depression and like continuously changing the antidepressant may not be effective. You need to there has to be something else. There has to be other treatments that can be beneficial. And that's why it's good to have treatments like TMS. So then if you take that same person who has a likelihood of only 15% of responding to a third antidepressant and you give them TMS, they actually have a 70% likelihood of responding, meaning that they will notice that their symptoms of depression are getting significantly improved. So that's why this treatment is important. That's why it's key. It's because so many people will be treatment resistant. So many people will not respond to the medications we have, and then we need other treatments. And TMS is effective in treatment resistant depression. And this is not just treatment resistance is not just common in medications. It's also common with psychotherapy too. Well, 50% of people who do psychotherapy, cognitive behavioral therapy for depression still continue to still will have significant symptoms of depression, yeah, even after completing psychotherapy. So that's why it's important for psychiatry to have multiple treatments available because not one treatment may not particularly work for somebody. So TMS, in terms of efficacy, like we said, like 70% will respond, meaning that they will notice a meaningful difference in their symptoms, and 40% of people will notice remission, meaning that all their symptoms will go away though. They won't have any symptoms of depression left. in that episode of depression. They still have a major depressive disorder, in that because we know that major depressive disorder is a chronic illness where the depression can come back. But after TMS, 70% of people notice that their symptoms are better. 40% notice that their depression has gone into remission. So what's cool right now in the research is that TMS is now expanding to other diagnoses. So TMS, if you think about it, it's just a tool to be able to stimulate the brain. It's not necessarily a treatment that's specific to depression. It's a tool that we have to be able to stimulate the brain. So theoretically, it can be used for other things. For example, neurologists and neurosurgeons are starting to use it for stroke rehab because we can put it over the part of the brain that may have been damaged and then try to stimulate that part of the brain. In psychiatry, we're starting to see if it can help with bipolar depression, anxiety disorders, PTSD, OCD, cognitive impairment, addictions, and pain. If we look at some of these conditions and we look at the early research that's been done, it's very promising. It's exciting. Um, for example, not too long ago, there was a systematic review and meta-analysis uh, that looked at 275 patients, almost 300 patients from 14 studies, and they did find that TMS for bipolar depression was effective. There was an odds ratio of 2.72%. So you're more 2.22, almost three times more likely to respond to TMS than placebo in terms of getting treatment of bipolar depression. And the efficacy rates were like almost similar to depression. Like again, where it's like 60 to 70% response and 30 to 40% remission. And again, the reason that we have it's necessary is because um, for all these other conditions, it's also because treatment resistance in these other conditions is also very common. 50% of people with generalized anxiety disorder fail the first antidepressant prescribed. Like I said before, psychotherapy, including trauma-focused cognitive behavioral therapy and EMDR, which is like the cornerstone treatment in PTSD. There's a high dropout rate, and two-thirds of veterans who completed these psychotherapy programs continue to meet criteria for PTSD. In OCD, 40 to 60% of people respond to treatments, leaving 40 to 60% of people difficult to manage. Um, and even in psychotherapy for OCD, which is exposure response prevention, like a particular type of cognitive behavioral therapy, 45% of people drop out or don't respond. So in terms of TMS for generalized anxiety disorder, there is strong emerging evidence that it can be beneficial as well. Generalized anxiety disorder is um, one of the most common anxiety disorders. It affects what, 6% of Canadians at some point in their life. Um, and it causes a lot of disability. In generalized anxiety disorder, people will have a lot of worries with various different things. Not that the worries are invalid or that they're not real. The worries are a lot of times valid, but the worry is just excessive. They worry to the point where it's excessive and difficult to control, and it causes them to feel restless and um, they worry so much that it causes them to feel fatigued. They worry so much that it makes them irritable or causes muscle tension or causes difficulty with sleep. It can lead to a lot of somatic or physical symptoms. It leads to like headaches and irritability, insomnia, sexual dysfunction. Um, and so a lot of people who are 6% of the population is struggling with generalized anxiety disorder, but only 50% of them are really responding to one of the first line antidepressants or 50% with psychotherapy. The evidence does show that it is fairly good, that it has promised to be effective treatment for generalized anxiety disorder. So we target the same parts of the brain that we target for depression, and that kind of makes sense, knowing that we know that depression and anxiety they tend to go together. Like a lot of times when patients are depressed, they're also anxious, or if people are anxious enough for a long enough period of time, they can fall into depression. So we use the same target the same areas of the brain. So we target the left dorsolateral prefrontal cortex with an excitatory stimulation, and we target the right side of the brain with like an inhibitory protocol because it's thought that the right side of the brain is a little bit overactive in anxiety disorders. And it does show that it can be promising. So as an example, there was the study's a couple years old now, but they looked at people who have generalized anxiety disorder and seen what the efficacy rate was, and they found that it did significantly decrease their anxiety scores by a couple of standard deviation points, which is pretty significant. And they looked, and at that time, a lot of the studies were smaller. Today, I think there's been some newer studies that are a bit that are more robust, but they've also shown similar findings. But you can see that it does the across all the studies that have been done, it is showing favorable results that people are noticing reduction in their anxiety with TMS. There was another study that they looked at 21 studies looking at almost what 1,500 patients. So that's pretty significant. 1,500 is a pretty good sample size. And they found that TMS did have a medium effect size, that TMS plus medications was superior to medications alone. So this is something that if was available, readily available to people who have anxiety disorders as an adjunct to what they're already on, it can be quite effective. And then there's some evidence for RTMS for post-traumatic stress disorder as well. And this is becoming something that's more researched more and more. In PTSD, there's evidence that the default mode network is shifted. So the normal pattern, like the default pattern of neural patterns is shifted to a state where there's stronger connections to the limbic brain and there's weaker connections between the amygdala and prefrontal cortex. So because there's less prefrontal control over the limbic brain, it leads to these symptoms of PTSD, the memory intrusion, the re-experiencing of traumatic events, because the brain is less able to control those emotional centers of the brain and those parts of the brain where the memories could be circulating. So they found that TMS for PTSD, there's emerging evidence that it can be effective. Um, so, like I said, I made this point before. It's just that PTSD can be quite challenging to treat many times, even with really good therapy. For example, I mentioned before that two-thirds of military personnel still met the criteria for PTSD even after doing the first line therapy for PTSD. In TMS, they did find there was evidence. They found that there was a significant reduction in the core symptoms, and they thought one study thought that it was a large effect size. And they found that both the excitatory TMS and the inhibitory version of TMS were both effective. And so people wonder like why, like maybe why is both excitatory and inhibitory effective? And I think it's because TMS, PTSD has numerous symptom clusters. So there's the reliving symptoms where you have a lot of flashbacks and nightmares where you're reliving the past trauma. Then there's the negative alteration in mood and negative alteration in mood and cognition. So that leads to, symptoms of like increased anxiety, depressed mood. It can lead to hypervigilance. And so the different treatment protocols that we use for TMS can be effective for the different symptoms that come with PTSD. For example, treatment to the right side with inhibitory protocol may help with some of the anxiety symptoms, may help with some of the anxious distress, whereas excitatory stimulation maybe helps with controlling reliving symptoms, like controlling flashbacks and nightmares. TMS has also been shown to show some evidence for OCD. So in OCD, like the cool thing about TMS with OCD is that we actually pair it with therapy at the same time. So the main treatment for OCD is actually something called exposure response prevention. Essentially, in OCD, you have these intrusive um, thoughts, images, or urges. And so one of the most common examples is that people have intrusive intrusive thoughts of worries about contamination, so they worry about getting germs or getting infected. And in response to those intrusive thoughts, they will engage in like repetitive behavior where they'll clean their hands repetitively or clean other things repetitively. Um, and the treatment with OCD is actually exposing people to those things that they're scared of. Um, so for someone with OCD who has OCD about contamination, they might actually get them to touch a garbage can in the most extreme example, and then not and then sit with that distress without being able to engage in some of the repetitive behavior that they do. So what we do with TMS is that people will actually do the exposure, and then when they're a bit distressed by not being able to engage in the compulsion, we then give them TMS at the same time, and it's thought that it strengthens those neural connections that help people get past OCD symptoms. And it is FDA approved now, and there's enough evidence to show that it is effective. Um, I won't go through like the details here, but basically, they did find that people do. If you compared TMS without TMS, in treatment as usual, maybe 13% of people will get better, whereas like 35 to 40% of people were getting better in the group with TMS. And usually, people who are getting the treatment are treatment resistant, so the response rates may seem low, but they're really low in general when people have treatment resistance in OCD. What's interesting is that TMS can now be used for chronic pain, which is actually really, really exciting. So a lot of people are starting to use TMS for chronic pain, and it's something that's becoming more and more popular. Again, it's based on the idea that like even in chronic pain, there's circuits in the brain that regulate how you feel about it or how you perceive that pain. So with a lot of chronic pain conditions, you end up having changes in the circuits that by which you experience pain and um, by the way it's modulated. So chronic pain is something that is when you have an unpleasant sensory or emotional experience associated with actual or potential tissue damage, and it lasts for more than 3 months. And pain is always perceived in the central nervous system. It's perceived in your brain, so that it's always up to some degree subjective. There's different types of pain. For example, there's uh, pain that arises from damage to nerves themselves. So often caused like conditions like diabetes or shingles or nerve compression or traumatic injuries. With neuropathic pain, the neurons system is essentially misfiring or sending inappropriate pain signals due to nerve damage. So the very circuit gets damaged, and then it's sending inappropriate signals or misfiring, causing pain. And then there's something called nocioplastic pain. So it's not like any specific nerve root that's damaged, but instead it involves altered pain processing in the central nervous system when the brain and spinal cord become more sensitized to pain signals. This change in pain processing can amplify the sensation of pain, even in the absence of clear injury or inflammation. And those are like conditions like fibromyalgia and irritable bowel syndrome. And so you can see that with many types of pain, and then the last type of pain is like a nociceptive. That's where there's actual um, physical pain that there's been damage to at the area. So like fracture, cancer, osteoarthritis. So many of the chronic pain conditions that we experience is because the very electrical circuit of that's processing that pain is damaged. And that's why TMS can help modulate those circuits because it's a treatment that actually um, directly connects with the neurons. So with pain, stimuli, when you injure yourself or you have some sort of injury, that stimuli can lead to lasting changes in the brain. There's altered electrical states, there's altered neural networks. In chronic pain in general, they say that there's a hypersensitization. There's an amplification of neural signaling within the central nervous system, so that things that weren't even painful now become painful, or you just become more sensitive. So how TMS works for chronic pain is that it's thought that it actually modulates if we give it over certain areas of the brain, it can actually modulate those pain signals. It can modulate the pain signals transmitted by the nervous system. It can reduce central nervous system sensitization by altering activity of specific brain regions involved in brain processing. And so it leads to the decrease in the perception of pain and disrupts the pain signals before they reach conscious awareness. There's neuroplasticity that's involved as well. It increases factors that lead to the brain to rewire itself and establish new, healthier patterns of neural activity. And then finally, TMS also just releases endogenous or natural opioids as well. And it decreases central nervous sensitization, where this nervous system becomes more sensitive to pain. So there have been a few studies that looked at um, pain and TMS, and I think there's been so many studies now that it is fairly high evidence. I think for there's one big study that they did, and they did find that it was um, when you put the TMS coil over the motor cortex of the brain, part of the brain that actually does have to do with perception of pain and perception of what you feel, that there is definite analgesic effect. So there's high RTMS over M1 results in level A evidence of reducing pain. Um, and then there's other studies that looked at more like other neuropathic conditions, and they did find that there was significant reduction in pain. So for example, in this study, they looked at 17 studies, um, and they did find that there was a significant reduction. These are just these studies are too busy. These slides are a little bit too busy, but basically they're saying that there is short-term and mid and long-term benefits from TMS for chronic pain. A condition that's very difficult to treat in general is fibromyalgia. A lot of patients suffer because of it. It involves pain throughout their body. And one study looked at 300 patients with chronic pain, and they did find that there was significant improvement in fibromyalgia for chronic pain. And I think there was a few studies that looked at that, and they did find improvement. They found there was improvement over when you put the coil over the motor cortex and over the left dorsal lateral prefrontal cortex, the part of the brain that we also treat for depression. They did find that there was improved quality of life and decreased disability from fibromyalgia. I'm a geriatric psychiatrist, so this is exciting for me that RTMS now is starting to have evidence for mild cognitive impairment and early Alzheimer's disease. So currently, these are conditions that there's no cure for. They're neurodegenerative diseases. Over time, people lose more and more of their functioning, and that can lead to more disability. And currently, there's no cure. But what we're trying to find is in medicine is like, is there any way to reduce that likelihood of someone progressing to dementia? If someone presents with like really, just mild impairment, is there anything that we can do to try to change their trajectory? And so there have been studies around the world now that have been looking at TMS with this, and there's been a few studies now that have shown this is early research, of course, but they've shown that there is improvement in cognition. I've had some patients of mine in Vancouver who are from the mental health team who, they wanted to try something. They knew that there was nothing officially available, but they wanted to try something, and they knew that there was experimental evidence for TMS. And for those patients we did notice significant improvement, surprisingly. Like, and of course, I can't generalize that to the general population, but it's exciting for us to have seen that. I saw one patient, for example, who came in, she's probably came in now 3 years ago, and she came in with um she was a nurse. She had been a nurse, retired, but she had very classic amnestic difficulties. You can remember things that happened recently, forgetting recent conversations, and she was beginning to have those very classic neurobehavioral symptoms that occur with Alzheimer's disease. She's trying to think that someone was mad at her when no one was really mad at her, or thinking that family was trying to hide something from her. We did TMS, and her MMSC score, or cognitive scoring, went drastically improved. And I said, like, it's been 2 or 3 years, and she's been stable. Like, her cognition hasn't declined much. We've also had a couple of other patients who are like that, who are, the dementia, the TMS didn't cure them, but it definitely has slowed it down. Like, there's another person who was diagnosed with the UBC Alzheimer's clinic that's definitely having as Alzheimer's disease, and it's been over 2 years and he's still living independently, still drives. There's been very little change in his cognitive scoring. So this is something that I think would be exciting for our country and probably for everyone in general. Like if this was studied more and made more readily available. And this slide is just showing that they did look at this meta-analysis looked at like 300 patients with Alzheimer's disease and MCI, and they did find that there was a medium to large effect size for its benefit. And finally, I just wanted to talk about our TMS for schizophrenia. So TMS is starting to be used for schizophrenia as well. And it's not a replacement for antipsychotic medication. It's not a replacement for psychotherapy. It's an adjunct treatment. So sometimes patients will be on antipsychotic medication. They're being followed by the mental health team. They have a lot of support, but they still have these ongoing symptoms. They can have ongoing auditory hallucinations, or they can have ongoing negative symptoms like anhedonia, difficulty to get pleasure from things, decreased motivation, decreased emotional expression. They don't find that their thoughts come as easily. And so these negative symptoms can be very impairing. And there's emerging evidence that TMS for uh, schizophrenia can provide some benefit. Is mainly used for like now the negative symptoms, the cognitive impairments, and some of the auditory hallucinations. Some studies have shown that RTMS may actually influence some of the dopamine and glutaminergic pathways and neurotransmitters. And the fact that TMS induces long-term potentiation or releases factors that are good for neuroplasticity is thought that that's maybe why it's also good for TMS, good for schizophrenia. And so it's early research. I would say that the evidence base is still emerging, but some of the preliminary studies that um, do have their limitations show that like 40 to 50% of patients are noticing some response when they have ongoing hallucinations. Like it can help with reduce some of those residual hallucinations. It can help with some of the cognitive impairments. So 30% of people notice improvement in attention, working memory, and executive functioning. The thing with TMS though is people will require maintenance. So a lot of times they'll do the index treatment and provide benefit, and they may require ongoing treatment to try to maintain that benefit. Maintenance treatment can be as little as once a week. For some, in rare cases, it can be more than that. And sorry, the slide didn't transfer here, but RTMS can also is starting to be used for autism spectrum disorder as well. Um, so there's emerging evidence that it may help with like social cognition and repetitive behaviors. Um, so people are starting to study, like if they can put it over the left dorsal lateral prefrontal cortex, right dorsal lateral prefrontal cortex, can it improve social cognition? Like, can it improve people's ability to understand relationships and get along with people better, have decreased behavior? And yeah, like they're really small studies today, but they're starting to show positive response. And when you add all these little studies up, it does show that there's possibly a positive effect for autism as well. What I wanted to do by like showing you all that about TMS is that it's an exciting treatment modality that's there, right? It's something that there's a lot of research being done. It can be used for so many different things. It can be used for obviously for depression, but then other psychiatric conditions that go along that are similar, like anxiety and PTSD. But now it seems like maybe we may be able to use it for like many other different things, like chronic pain syndrome, mild cognitive impairment, chronic pain syndromes, or autism. You might wonder, like, again, like how can one treatment do so many different things? It's just again, TMS is just a tool that allows us to be able to stimulate different parts of the brain, and we can use different frequencies to affect different parts of the brain. At the end of the day, all of these conditions affect the brain, so it makes sense that targeting different areas would lead to improvement for different conditions. I also want to contrast this treatment with ECT. So ECT is it's electroconvulsive therapy. It's shock therapy, um, and it's different. It's a lot different than ECT, and then a lot different than RTMS because it's performed in a hospital under anesthetic. So basically, what happens is that when someone receives ECT, artificially inducing a seizure. And it's thought that somehow that seizure resets the circuits in the brain that regulate different things. So, for example, it can reset the circuit that regulates mood and helps that brain circuit shift looking more like it is when it's healthy. Now, obviously, it's not the actual science isn't as simple as it's resetting. There's different mechanisms of action that are coming in place. It's thought that like somehow that seizure releases pro-neurotrophic factors. Those are factors that are good for neuronal development, neuronal connection, neuroplasticity. It leads to like the actual DNA releasing various factors that help rewire the brain, and it can lead to a significant improvement in symptoms. But it's more invasive. It's a lot, obviously much more invasive, one more invasive treatments we have in ECT in that we have in psychiatry in general. An anesthetic puts you unconscious. You're given a muscle relaxant, so you don't actually see the seizure in the body, and you just see it in an EEG. And modern technology has made it really safe. Like today, it's just a very small impulse that goes for just a few seconds. There's an anesthesiologist there making sure your blood pressure, heart rate, and everything are stable. Um, Obviously, there are side effects, but it's not like it was before. It's definitely not. It's not a barbaric treatment. It's very makes a big difference to a lot of people. I work in a geriatric psychiatry inpatient setting. We've definitely seen people who weren't able to get out of bed, be able to feed themselves, be able to return to living independently with ECT, people who return back to their lives with it because of it. They go from needing total care to being living independently. So ECT, yeah, the day that you get the treatment, your memory might be obviously not the greatest. Um, and in and around the time of ECT, your memory might be a little bit fuzzy, but after ECT is done, there's no effect on your ability to retain new information. It doesn't affect your IQ. It doesn't change your personality. 1 in 10 people do say that like a distant memory from the past is a little bit more foggy or a little bit more difficult to retrieve. But overall, like the treatment is quite effective and helps people return to their lives. We primarily use it for mood disorders, so like severe major depressive disorder, but we also use it in treatment refractory bipolar depression and manic episodes we can't treat them. Um, for schizophrenia, when there's catatonia, psychosis, or neuroleptic malignant syndrome, when there's symptoms of schizophrenia or that are difficult, that are not responding, especially the positive symptoms, TMS can sometimes help. TMS is, sorry, ECT. ECT can help. And ECT is starting to be used for like other things too. Like it can be used for um, Parkinson's disease. Sometimes it makes Parkinsonian symptoms better, the motor symptoms along with the mood symptoms. There's some evidence that it can maybe help with treatment-resistant OCD that's comorbid with depression. So overall, like I would say, yeah, it's treatment when someone has very, very severe illness or treatment refractory, it is very effective. But obviously more invasive and takes more to do. This is just evidence-based for ECT. It is quite effective. 70 to 90% of people who don't get better with other treatments will get better with ECT. Um, it's really good for like suicidality. When people have suicidal ideation, it can take them out of the suicidal ideation very quickly. Um, it's effective for bipolar depression. I think the evidence is pretty strong now. We touched upon this already, right? Like the negative effects of ECT, because it involves anesthetics and it involves the small electrical stimulation, that there can be a little bit of side effects, but overall, I'll say the benefits outweigh the risks for the vast majority of people. Again, like ECT is most effective for major depressive disorder, bipolar disorder, and catatonia. And it has emerging evidence that it can have pretty moderate response in schizophrenia and Parkinson's disease. Finally, last treatment that we wanted to talk about was ketamine-assisted psychotherapy. So our TMS clinic is actually embedded in a clinic that also offers ketamine-assisted psychotherapy. So we're separate clinics, but I think we both end up treating the same patient population, people who are treatment resistant. And so when patients come to our clinic, we're also able to connect them to ketamine-assisted psychotherapy if that would be appropriate, if something that they want to do. So what is ketamine-assisted psychotherapy? Obviously, you've heard of ketamine before. Ketamine is an anesthetic, it's a dissociative agent, but they found that it's also really effective in depression. It has really high um, antidepressive effects. So ketamine-assisted psychotherapy is an emerging approach that combines the unique effects of ketamine with the structure and support of psychotherapy. So ketamine itself is a fast-acting NMDA receptor antagonist. So it's something that fastly acts on one of the receptors in the brain, and it affects the brain's glutamate system. It's one of those neurotransmitters that are essential for life, um, and it's essential to neuroplasticity, and the brain's ability to form and recognize synaptic connections. The neuroplasticity is particularly beneficial in treatment-resistant depression, PTSD, and anxiety disorders, where there's this rigid negative thought pattern. So unlike antidepressants, which work by increasing serotonin and norepinephrine, ketamine operates differently by blocking NMDA receptors. Ketamine increases the availability of glutamate in the brain, which can trigger a cascade of neurochemical events that lead to rapid and significant improvement in mood. So it leads to release of BDNF, brain-derived neurotrophic factor, a protein that supports survival and growth of neurons. And then in ketamine-assisted psychotherapy sessions, patients are typically given a sub-anesthetic dose of the ketamine, and at these levels, it actually induces a dissociative, dreamlike state where people often experience a loosening of rigid thought processes and softening of the defense psychological mechanisms, things that are like preventing someone from dealing with some of their trauma. And when you pair it with therapy, it creates this window where patients can access repressed memories, face unresolved traumas, or gain new perspective on deeply ingrained issues. And for many, this state feels profoundly introspective or even spiritual. And the therapist's role is to support the patient's journey and experience. So my experience, it is quite effective. I've seen people have received it in Vancouver and in Edmonton and in Toronto, and I've seen people have a lot of improvement. And it can be done. It's still obviously it's the newer treatments. There's still evidence research being done, and it's still technically off-label, but it seems like it can be quite effective. It's really effective for treatment-resistant depression, like what I talked about. And the highest response rates are for highest response rates are for major depressive disorder, bipolar disorder, and catatonia. Um, but we don't typically use it for catatonia. Most people, it's because in outpatient treatment, people would think that it's yeah, it's not, and studies I think are limited in catatonia, but it's more for treatment-resistant depression and bipolar disorder. That's where it has the most evidence. And probably the emerging areas of research are like post-traumatic stress disorder, OCD, and chronic pain conditions. So interesting, ketamine likely affects the circuits that modulate pain, and ketamine has anti-pain properties as well. The other good thing about ketamine is that it's often used in emergency settings for suicidal ideation because it can have anti-suicidality properties within a few hours, which has been which is important. It's something that can help a lot of people. I mean, there's obviously some uh, adverse effects of ketamine. Sometimes people can feel a bit, especially during the treatment, they can feel a bit anxious, or they can have their blood pressure can go up, they can feel dizzy, nauseous. These are things that are more transient. People experience them and then it goes away. Overall, though, um, most people notice a lot of improvement. There's a slight psychological risk as well because like if you don't have good defense, if you don't have some good emotional regulation skills or distress tolerance skills, sometimes things that the treatment brings up can be distressing. But that's the same with any type of therapy as well. Like people have to get to a place that's appropriate for them to do this treatment. They need to have, regardless of therapy, usually the first thing you need to do is actually first develop some basic emotional regulation skills, distress tolerance skills, and then you're in a better place to process past trauma. But yeah, that's still essentially what we wanted to talk about today, which is give you this overview of these treatments that I think are starting to become a little bit more well known, but are still new to a lot of people, and may potentially provide a lot of benefit to people. And so the treatments for mainly TMS and ketamine assisted psychotherapy. ECT has been around for a while. I think most people know about it, but it's also quite effective and something that can benefit a lot of people. Okay, so in our clinic at Feel Like our TMS, we're able to, our Toronto clinic, we're mainly our TMS clinics. We treat with repetitive transcranial magnetic stimulation in downtown Vancouver, downtown Toronto. And we're also, like we said, we're in a clinic that offers ketamine assisted psychotherapy too. So if people wanted to access that type of treatment, we're also able to connect them to that treatment as well. Okay, so I can leave it. Sorry it ended up taking so long, but yeah, at this point I can answer anyone's questions and then we can leave it there.
Thank you. I have gone to many sessions, and this was the most informative session I've been to. I really learned a lot, and we have some questions in the chat, and I have questions being sent to me uh, through my
Yeah,
Gmail. So
sure.
one is, can RTMS induce seizures in a patient with schizophrenia and epilepsy?
Well, schizophrenia and epilepsy are two different conditions. So if someone just had schizophrenia, no, it does it's they're not at increased risk. One of the risks with TMS is the extremely rare risk of inducing a seizure because we're using those electromagnetic pulses is considered to be a risk of 1 in 10,000. So almost the same risk of getting struck by lightning. Um, and it's not the risk of inducing epilepsy or recurrent seizures. It's just the risk of having a one-time seizure during treatment, but it's really low risk, like 1 in 10,000. But certain people can be at increased risk. So those people can be people obviously who have an epileptic disorder, or people who, um, if they've drank a lot of alcohol or alcohol withdrawal, they can put them at risk. But what's interesting though, in some places in the world, they're starting to use RTMS as a treatment for epilepsy, for treatment-resistant epilepsy, because they're using, although there's a risk of inducing the seizure, it also brings up the seizure threshold. So, for example, the University of Calgary Children's Hospital, I believe there was, last time I checked, there was a big study where they were using RTMS to actually reduce seizures in youngsters. But in general, the vast majority of clinics, including our clinic, will not treat people who have epilepsy.
Mm, Okay, thank you. The next one was, can ketamine become addictive?
Yeah, I mean, ketamine there's been a lot of news articles about like there were ketamine people have used ketamine where they use it in like, but in the therapeutic setting that we tend to use it in, we don't tend to see people get addicted or abuse the ketamine because first off, the patients that are being selected for ketamine-assisted psychotherapy are usually less likely to have an addiction, um, likelihood of addiction. And then secondly, just the way that it's administered and the focus is different. Like in ketamine-assisted psychotherapy, we're actually using the ketamine to not necessarily, we're not giving it such high doses and such fast rates that you're getting this high from it. It's more about like being able to focus past trauma, focus on internal experiences, and then taking those experiences and then processing it with a therapist. So in that setting, we don't find that people end up like becoming addicted or abusing ketamine.
How does how does ketamine compare with TMS in, I can't read this.
Oh, and bipolar disorder. That's a good question. And I would say that both TMS and ketamine or any treatment that treats bipolar depression, the biggest risk is switching the person to the opposite, switching them to hypomania or mania. It's a lower risk, especially if people are on a mood stabilizer or antipsychotic medication. It's less likely to occur. Um, the few times that it's occurred with TMS when we've treated, um, people have reverted back to have come out of the hypomania like almost immediately after we stopped the treatments. Um, but in terms of like which one's better, which one's more effective, it's hard to say because there hasn't been, I don't as far as I'm aware, there hasn't been head-to-head studies with comparing TMS and ketamine, but they're both off-label emerging indications for both, and I've seen people from both get better from it. And I think someone asked, is TMS effective for somatic symptom disorder or functional neurological disorder? Yeah, there's emerging evidence that it does. Yeah, we definitely had people who have had significant somatic symptom disorder, functional neurological disorder, and they did get better with EMS. I definitely have seen them improve. We've had, I think, in for some reason, our Calgary clinic, the clinic I help people in Calgary, the neurology clinic has become aware of TMS, and they've been sending a lot of patients with functional neurological disorder to our clinic. And a lot of those, and surprisingly, yeah, we've been treating off label, but I've seen people get better from it. Um, and then is there in terms of like order? I think it just really depends on patient preference, right? So I would say TMS still probably has the most stronger evidence base because it's been around a bit longer, it's been studied more. It's um, for some conditions, it definitely has evidence where ketamine doesn't. For example, TMS definitely has evidence has more evidence for chronic pain, for functional neurological disorder, whereas ketamine has less. But yeah, usually I just leave it up to the patient in terms of which one they want to pursue. But in general, you do both. You would do TMS or ketamine before you would consider ECT. If you can, if it's feasible, of course, these treatments have to be available where you live. Um, these treatments are usually private a lot of times, and so there can be affordability or barriers for people to access it. The next question was, how effective is ECT and RTMS for very treatment-resistant schizophrenia? Would you recommend for such a Yeah, it really depends on the symptoms for RTM for treatment-resistant schizophrenia. So some people will have residual positive symptoms. So there's residual hallucinations or auditory hallucinations. It can have negative symptoms as well. Studies show that people can have response. So I think it's fair for people to try. So like let's say, but it's not a replacement for like the antipsychotic medication. It's definitely not a replacement for antipsychotic medication. It's definitely not a replacement for the other treatments. But can it augment? Maybe it's possible. And I would say ECT is probably more appropriate when people have the psychotic symptoms like the delusions or paranoia or the hallucinations that are not getting better. They seem to be a little bit more severe and they're causing more functional impairment. And that person, I would tell them to do maybe ECT. And ECT does have evidence to be able to help with treatment-resistant ECT symptoms. Is treatment-resistant schizophrenia symptoms. Um, and is ketamine more likely to induce mania than TMS? I don't think so. I think they're both about the same. But in general, if patients have bipolar disorder, generally want them to be on to be on some sort of mood stabilizer to prevent that risk of switching. Yeah. And then someone asked, is there a criteria to suggest selecting a clinic? Um, yeah, which is I think if you're finding a clinic, as long as it's done by someone reputable, like if it's done by, you know, if there's, they should have a psychiatrist or doctor that's involved that's appropriately assessing you, and that appropriately gets you the appropriate diagnosis. And then, yeah, I would say in general, these clinics that offer neuronavigation, that's if you can find a clinic that is neuronavigation, that may be more effective. Neuronavigation essentially just means that the TMS device is linked to uh, a device that reads an MRI of your brain, and it more accurately places the quill where it should be. And studies do show that it can be effective. And in terms of like, you don't need a referral for TMS. So for these treatments, because they're private, I get feel like RTMS, you can just call the clinic and then you'll generally be assessed by one of the doctors, a psychiatrist, and then they'll tell you about whether the treatment is effective for you or not. And the cost, there's no cost for assessment. It's just for the treatment itself. People will have to pay, unfortunately. But in the future, maybe there's more and more public programs that are arising. But even when there's public programs, it's a bit limited. So I also work in Alberta. And in TMS, we do have TMS programs in all our hospitals there, but it's very restrictive. Like it has to be like very treatment resistant depression. They won't really treat for these other off-label purposes. But hopefully in the future, as the evidence gets based more, that'll be covered by the government, or hopefully um, it will, more and more people's insurance will cover it. I think insurance is starting to cover more and more people's treatment because different insurers are recognizing that it can be effective. Um, for ketamine, I would say that on average, people are doing about 6 to 8 treatments for an index course, and then people may be doing maintenance after that. So maintenance can be one treatment every 4 to 6 weeks if they need it. Some people don't do maintenance.
I had to go to my phone because we had a power outage.
Oh, what's
So my computer isn't working. So now I'm on my phone. So I have some other questions here. So would TMS work on mild cognitive impairment in schizophrenia?
Well, that's
You
what they're
said it would
studying,
work.
right? They're trying to see if it can. And early studies show that it can possibly I think I showed you that one study where they like 30 to 40% of people notice some improvement in cognitive function with in schizophrenia. Um, yeah, but more studies need to be done. Yeah, so it's an area where more research needs to be done. Unfortunately, like a lot of the research in TMS and ketamine are not done as intensely as like medications, just because there's no money for drug companies from these treatments. Ketamine has been generic for a while, and of course, TMS is not doesn't involve medications.
So my next question here is, what is the is there a different protocol for TMS at a hospital that versus a private clinic? So for instance, at a hospital, they may have only a certain protocol that they do for each person and the amount of sessions. Also, sometimes you don't know if you're doing it for research, you're not sure if you're going to get the sham or the real thing. Whereas a private clinic, you might get a more comprehensive treatment, perhaps, or longer
In
protocol.
general, like that's what we see. Like so first off, in public programs, it can be restrictive. So they usually generally only treat for what's Health Canada approved, which is treatment resistant, true treatment resistant depression. So they might require you have actually tried a certain number of medications for a certain degree of time before they'll treat. And then they just usually just use the standard protocol. Whereas like in private clinics are more willing to treat off-label indications, but of course evidence-based. But so things that may not be Health Canada approved yet, but have emerging evidence to help. So people with PTSD, anxiety disorders, chronic pain conditions, those things the hospital won't treat, but private clinics will. And then yeah, the protocols we in private clinics they tend to change. We have access to there's more flexibility with the protocols that we use. So.
Okay, another question. Sorry, we have so many questions here. Um, TMS, you talked about movement disorders. Can it help? Some antipsychotics may cause TD, tardive Would that
Hmm.
help with tardive
I have to see if it has any been studied. I don't think it's known treatment for TD, but I think there might be some research going on with that. Maybe just like 1 second. If it is, it's just really early research too.
You mentioned off-label. So what do you mean by off-label? You've mentioned a few. Is schizophrenia off-label or schizoaffective off-label?
Yeah, off-label means that the medication or the treatment that you're using is Health Canada approved for that indication. To get Health Canada approval, it's like pretty robust, like giving you like really large studies to get that approval. For example, you need for treatment-resistant depression, they had to do like very big multi-site double-blind placebo-controlled trials before it got approved. So for emerging indications, it might take a long time for that to officially get the Health Canada approval. For example, we know that TMS in these early research in these early studies do show that it's effective for anxiety, for chronic pain, um, and many studies show that meta-analysis show that it's beneficial. Um, but to get the official Health Canada approval stamp means that there's going to have to be bigger research studies done before they'll give that stamp. That might take a while for like chronic pain, for example. It might be like 15 years before that happens. For cognitive impairment, same thing. It takes a long time to get to that degree of research. So we tell people, yeah, these are off labels. Technically doesn't have that high, like super high degree of evidence that's required for Health Canada approval. And that doesn't mean, and the research is still, yeah, it's still limited research. Same time, the research is showing like it can be potential benefit. That's what's an off. You're doing it off label. A lot of times when you take medications too, many times your doctor is actually prescribing it um, off label for different things.
Another question is, let's say you've done ECT, a number of years ago, and some antipsychotics may stop suddenly working. And
Mhm.
some people at 2 years have passed, and they're like they've been on it for 10 years, let's say, and then it stops working. Then they may, after another 3 or 4 years, the medication may stop working. Can they do ECT again?
Yeah, you can always go back to ECT whenever treatment, when if you had a course of ECT and it was effective, and then you relapse the symptoms, yeah, you can always go back to ECT. Yeah. In fact, a lot of times when people do have recurrence of symptoms, they do tell them to go back to ECT unless there's a reason they don't want to. Like sometimes people they don't like the fact that they're giving anesthetics, they don't like going under, they don't like how they feel the day that they get the treatment. But yeah, ECT can be effective. If it was effective before, it can be effective again.
What is DTMS?
What is
And
deep TMS? Yeah. Yeah, so there's different, I think, how do I put this? Essentially, deep TMS is when you're using TMS and it goes a little bit essentially deeper into the brain. So for certain conditions, you need to do that. For example, um, when we're treating for depression, we're treating more the cortical area of the brain, left dorsolateral prefrontal cortex. But we know for like some other conditions like OCD, it's actually recommended that you target deeper areas of the brain, like the orbital frontal cortex or the dorsal medial prefrontal cortex. And to get to those parts of the brain, you actually have to have a coil that can get to um, that place. So most TMS, pretty much all TMS devices have that ability. Like for Meg Venture, it's different, and then there's different TMS companies. For example, we use Make Venture and Make Venture they have a coil that does like subcortical TMS, and then they have a different coil that goes deeper. And then some TMS devices involve you wearing a helmet, and those helmets go deeper. So, but yeah, deep TMS just means using a stronger magnetic field to target a different area of the brain. It doesn't necessarily mean better, just maybe for certain conditions it's more appropriate.
people are asking about sessions. How many sessions? Like I know some people with ECT, and some people get 35, some people get 65. Is there a
For
maximum
for a number of treatments for ECT
for
or
schizophrenia and also uh,
for
like,
schizophrenia, it depends. Like usually, in general, index treatments are usually just 30 treatments. That's over 6 weeks, and then maintenance is where you try to maintain the benefits of the treatment ongoing. And that's different for different people. It's like For example, I think your son required a little bit more, did more maintenance treatments, but in general, it's supposed to be just like once a week ongoing, and then you can decrease the frequency over time.
Yeah, I was referring, I'm sorry, to ECT.
Oh, ECT is usually about 12 to 15 sessions, generally, on average.
So I know a couple of people, clients who have 30 sessions and some who've had 50 sessions, so is that,
So, yeah, it's hard to know if those are like all those are indexed though, right? Because usually the index course, meaning that when you're acutely sick, those ones they'll give, back to back. People can go up to like, yeah, 12, 15, 20 sessions sometimes. But then the people will then switch to maintenance where they're still receiving the treatments, but it's to prevent them from the symptoms coming back. And the maintenance treatments can be a lot less. And sometimes in general, it's only like once a month or less than that.
thank you
Okay,
very
great.
much.
Thank you.
We
Okay.
appreciate your time and all the information.
Okay, have a good night. Bye bye.